which we will. Hello and welcome to Health Live at Seniors Today. Tomorrow is World Heart Day, and we thought it would be appropriate for us to have a session on cardiac health, care for a healthy heart for seniors, as we've called the topic. And we thought it would be appropriate to have a senior heart specialist, a cardiologist, and of course, a lot more, Dr. Sanjay Rajdev. I'll introduce Dr. Rajdev before welcoming him. Dr. Sanjay Rajdev is an accomplished cardiac and vascular interventionist with fellowship training in the USA. He is with the Hinduja Hospital in Khar in Mumbai. After his fellowship, Dr. Rajdev worked at the Seven Hills Hospital in Mumbai for 8 years. This was followed by a stint at one of the UAE's largest healthcare provider, the New Medical Center. Dr. Rajdev spent over 6 years in Abu Dhabi, where he continued to achieve several firsts in the hospital and in the UAE. He then returned home to Mumbai, where he established the Rajdev Mediclinic, a polyclinic which has state-of-the-art systems for non-invasive cardiology evaluation. This is in Andheri West in Mumbai. His core interests include all types of interventional cardiology, like coronary angiography, angioplasty, peripheral angiography, and angioplasty, closure of heart defects, treatment of thrombotic vascular disorders, and pacemaker implantation. And as I mentioned, this is being held. This special session is being held on the eve of the World Heart Day, which is tomorrow. Sorry, we have a problem with our technology today, but I'll just get it. Thank you and welcome to Health Live at Seniors Today. Dr. Rajdev, how are you?
Very good, Pratibhanji. Thank you so much for the nice introduction. I appreciate it.
I must be very thankful to you. Dr. Rajdev is in Bhopal today. He's with his family, and he has specially joined this thing because World Heart Day is a very important, if I might say, event in the calendar of all cardiologists across the country, and he is taken time off from his personal schedules to be here. So thank you very much, and over to you with your presentation. As always, just a few things to note. This session is advisory in nature. While the doctor will give you advice whenever you require, but there's no alternative to meeting doctors and getting a clinical examination whenever required. So please do that. Also, do remember that the video of this session will be up on the Seniors Today website on Monday evening. So you can watch it, in case you missed out anything on the presentation today, you can always watch it then. And of course, take full advantage of the fact that we have such a senior doctor in the house and you can ask all the questions. Please do remember to put them in the chat window and I will address the questions if it's not being a repeat. Right. Thank you. Over to you, doctor.
Thank you, Pratibhanji. Thank you for all the people who have taken out their time watching this particular presentation. I will start. So I will start off by my first slide, which shows the global life expectancy diagram. So if you see, on an average, people across the world, they live for an average of approximately 71 years. People in the European areas and the Americas, they live longer. South Asians and Africans, they live a little lesser. But on an average, about 71 years is the average life expectancy across the globe at this point in time. And this is just a representation of the same. If you see this, this is a disease-free life. That means the productive number of years which a person has in many of the countries across the world, approximately 63 to 64 years. And if you see the difference between the life expectancy and the healthy life expectancy, it's approximately 9 years. So on an average, approximately 9 years is what people struggle or they are unwell during those periods. For example, if you take COVID 2 years, the 9.2 years will account for the COVID time that was lost when people were suffering from COVID infection. So essentially, we're talking about 64 years of healthy life and approximately 70 to 73 years, depending upon which continent you belong to. And it is these 9 years which are important because as seniors, we need to take care of these 9 years. We need to make this graph shift from 64 years to 73 years. And this is one of the recent articles in Lancet, which is a very recognized journal across the cardiovascular world. And it suggests that, as we all know, that high blood pressure and diabetes and cardiovascular disease, these are the most rampant and the most prevalent acquired diseases in the community, which cause for a lot of lives lost. There are many people with hypertension, approximately 5 times and 4 times more than the diabetes. And they are responsible for causing a lot of strokes and heart attacks, as you can see over here. On the other hand, if you have got diabetes at the age of 30, 40, and 50 years, you would be dying about approximately 14, 10, and 6 years respectively earlier. So hence, we need to recognize these particular risk factors and try to intervene in time so that we can catch up on those 9 years of life years lost. Cardiovascular disease on an average approximately is the biggest killer across the world. It causes approximately 30%, is responsible for about 30% of all deaths in the world. Now, if you see this individual risk factors, the high blood pressure is the single most important factor, which would cause a life lost. And the next to follow are would be tobacco, high blood glucose, which is diabetes, physical inactivity. And if you would remember, if you would recognize, overweight and obesity is something that we're going to talk about in this talk. Now, if you look at the age years at which these particular problems start, diabetes starts to affect you at the age of approximately 25 years, although the incidence is very small. Recognizable diabetes incidence can be seen beyond the age of 35 years, so you should be cautious and careful to start screening yourself around that particular age. Similarly, if you look at the cardiovascular diseases that mirrors the diabetic portfolio, and that starts to affect you approximately around that age, around the age of 35 years. This is something that we see in each other, but we don't recognize this as a risk factor for coronary artery disease. Again, according to this 2024 Lancet study, 70% of India's urban population is either obese or overweight. So either they are yellow or they are orange. And on the other hand, ideally they should be either blue or in the green section, where the BMI should be less than 35 years of age, 35. There are some unfortunate factors attributable to the coronary artery disease in the Indians. We are characterized by higher relative risk burden, earlier age of onset, higher case fatality, and higher premature deaths. And there are several responsible reasons that have been assigned to this particular observation. Most of them are that we have got some genetic factors which predispose us to early premature coronary artery disease and death. There is more of inflammatory states in the Southeast Asians, including Indians. There are abnormalities of lipid metabolism and glucose metabolism, and there are some epigenetic influences also that increase our cardiac risk. The question is, can we do anything about all these things? Most of us who are hearing, for example, this particular talk, let me ask a question to them. Are we all afraid of heart attacks? Well, the question would be yes. Why? Because we are seeing many youngsters, even those sometimes who are under 40 years of age, dying unfortunately with acute coronary syndrome or acute heart attacks. However, are we afraid of developing kidney failure or heart failure? Some of you might ask me, what are you asking? I mean, probably we are unaware of this particular risk. Do we have to calculate our risk of kidney failure or heart failure? Uh, well, if you go into the community among the friends and the people that we live with, there are many advisors. And the common advisors would be for any common condition that you might suffer, like hypertension, diabetes, or coronary artery disease, कि मेरा डॉक्टर अच्छा है उसको दिखा दो, इसको भी दिखा दो, उसको बहुत फायदा हुआ था, उसको दिखाते हैं, बाबा का चूरन लेते हैं, बाबा की भूसी लेते हैं, एंड गूगल तो है ही हमेशा, गूगल इज a friend of everybody. Let's talk about science now. My observations have been for the last 25 years that each one of us have gotten access to doctors. They are usually family physicians or the GPs. We often Google our friends, relatives who have been treated by a particular specialist. No one tends to go to the same doctor on their recommendation. Places slash doctors where our experience hasn't been great, we avoid. Seeking second opinions have become common. We do encourage people to take second opinions nowadays. We are often influenced by the experience of our friends, family, neighbors, and co-workers. An important thing, which is kind of practical, is that there is a knowledge-based variation in the doctors. That means all of them, all the doctors, they are not on the same page. Everybody has their own thoughts and processes behind giving their opinions. So it is always good to kind of check from a couple of doctors to see if they all say the same thing. So let's presume if nothing is wrong with us, how do we stand to benefit from this particular lecture? So we're going to understand very quickly. Since I'm a cardiologist, I'm going to speak about heart. What is heart and how does it work? What are coronary arteries? Who is at a risk of developing coronary artery disease? How do we measure that risk? Are there any mathematical models like E is equal to mc square available? Just like in science, how we understand how high blood pressure increases the risk of heart attack and stroke, adaptations to cut down the calculated risk, and there are other factors which might be of some help. So for example, this cartoon representation on the right side, the right things that you can see, these are the small 2 to 3 millimeter coronary arteries. These are arteries which arise right from the bigger artery called the aorta, just at the base of it, and it supplies the muscle of the heart. Any problems with these coronary arteries, any blocks in these arteries, any clots in these arteries leads to complications of ischemia. And when we see them in the cath lab or in the operation theater, we see them as black and white. And this is for us to understand and for you to know that this is how we diagnose problems in the coronary artery spectrum. So what is a heart attack then? Well, heart is a muscular organ, as we just discussed. It pumps blood to all parts of the body, but it also needs its own quota of blood supply. And the small arteries which supply blood to the heart muscles, these are known as the coronary arteries, and any blockage sudden of these arteries leads to potentially a condition called as a heart attack. So how do we measure that? Well, if you correlate with people with who drink and drive, there are more chances that they might meet with an accident. It's not an absolute certainty, but definitely the probability becomes more. So who in practicality gives more likely to get heart attacks? Well, there are people who have got high blood pressure, high cholesterol, high blood sugar, those who smoke, and obviously there are some genetic factors beyond our control. And sedentary lifestyle with more consuming than burning are the reasons why one person is likely to get heart attacks. But what causes the sudden heart attack? Why do those arteries they rupture, they block, they accumulate a clot? Well, if you look into that from a scientific perspective, this is on the right side is a coronary section. These are the small 2 to 3 millimeter arteries which have been cut open in a post-mortem specimen, and you can see that there is a vertical oval yellow thing over there. This is known as the cholesterol deposition, and that yellow thing is separated from the white one, which allows the blood to flow by a very thin black margin. Now, if that black margin gets ruptured for some reason or the other, then the yellow thing or the cholesterol gets exposed to the flow of blood. When such a thing happens, the clot formation occurs very fast, and sometimes it can lead to something totally occluding this artery, leading to the clinical symptoms of a heart attack. Excuse me. Whenever you get such a kind of a heart attack symptoms, the first thing that one should be considering is to do an ECG. And it's for your doctor to interpret what kind of an ECG changes are there. Some changes are severe, some changes are less severe. And if you see again a cross section of a postmortem specimen, on the right side, you see the black thing which has totally occluded the artery. It is no blood flow going across into that part of the heart, and this leads to a massive heart attack. On the other hand, this particular postmortem specimen also, there are people who die although they don't have a complete heart occlusion in the arteries. This is known as a subtotal occlusion of the artery, where a major part of the artery is blocked, but some flow continues. And this is known as a less severe variety of a heart attack, but nevertheless, both of them are life-threatening. Again, this is an example of a less than 100% occlusion because some blood flow continues to flow. So how do we measure this risk? If we are at a risk of heart attack in this community, how do we measure our risk? Well, somebody can predict on my future, one would tend to ask. The answer is yes and no. The why is because yes, there is a probabilistic designs. There are probabilistic models which are available, which can help you to understand your risk of heart attack, stroke, heart failure, and kidney failure. And why not cancer, lung lesion, liver disease, and brain disease? Well, it's beyond the scope of our talk. So let's take a look at some of the commonly available cardiovascular risk prediction models. This is the oldest one of them. This is known as Framingham Risk Score model, and this has been available since the last 7 decades. And if you see, the salient features in this particular risk model are age. So for example, more the age, more the number of points you get. SBP is systolic blood pressure or the higher of the blood pressures. So you've got a higher pressure and a lower pressure. So you go by the higher pressure, more the pressure, more the points. And if you look at the third point is the cholesterol, well, the cholesterol is also more the cholesterol levels, more the points which are assigned to this particular individual. There is a good cholesterol also. The earlier prediction models took into consideration the good cholesterol also. If you got low levels of good cholesterol, that again you get higher and higher points. And on the fifth step, if you see, there's a smoking status. So when you put them all of them together in a mathematical model, you get some idea about your risk of 10-year risk of coronary artery disease. That means whether you're likely to get a heart attack in the next 10 years or so. And the 10-year risk has been described as low risk, medium risk, and high risk. So when it is more than 30%, it is high risk. 10 to 20% is medium risk. Less than 10% is low risk. The Europeans, they have a different method to apply. They use something which is similar, but it is known differently as the score charting. Again, this takes into account several factors, just like the previous one. So it is different for men and women, but again, the smoking status, the age of the patient, the blood pressure, the cholesterol. So if you would care to notice, both these scores models are more or less the same, except that the points are different and the percentage points become different depending upon which score you are using. And when you put them into all together and sit with the patient and decide upon the risk factor analysis, then you would come to a conclusion that either if they have a low risk, well, the recommendation is something different. If they have a borderline risk, the recommendation letter is something different. If they've got a high risk, the recommendation is something different. And if they fall into this intermediate zone of 5 to 20%, then there are some additional things which the doctor can order. And some of these additional things are the reason why we are talking today. And these would include persistently elevated triglycerides, which are a different thing than the ones which are used in the scoring systems. There is a protein known as high sensitive C-reactive protein. Again, a level of more than 2 indicates a high risk. So if you are falling in the intermediate risk category and a doctor orders these things would put you either into a low risk category or into a high risk category, depending upon how many of them come positive. Another important features here is to calculate another subfractions of lipid profile known as LPA and ApoB levels. So again, if these levels are high, then your intermediate risk turns into a higher risk. So this has to be done in consultation with your cardiologist or your MD physician, whomsoever you go to. Now comes the interesting part. This is what we've been practicing for the last 7 decades or so. There have been multiple risk factor models, and they use variety of risk factors to assess your risk of heart problems. But these heart problems are limited to either a heart attack or a stroke or a cardiovascular death. Now we come to something which is also defines your risk of developing heart failure and chronic kidney disease, or in simple terms, kidney failure. So heart failure and kidney failure have become the newer models on the ground, which people are exploring and investigating. And there's a real benefit in understanding our risk of heart failure and kidney failure. We can take preventive steps at this age so that in the next 10 or 20 years, we don't land up into one of these conditions. So this is known as the CKM syndrome. Now this particular model uses another risk factor scoring system, and this risk scoring factor system not only tells us about the risk of heart attack, stroke, and death because of these cardiac reasons, but it also tells us our risk of heart failure and chronic kidney disease or kidney failure. This is known as the Prevent Online calculator, Prevent CKM calculator. Since more and more evidence is kind of piling on and we are able to understand our risk factors better, this scoring system gives you a prominent and a practical way of understanding your risk of not only a cardiovascular risk for the next several years, it also gives us an estimate of our kidney and metabolic syndrome health also for the next 10 to 30 years. An important differentiating factor between this particular score and the previous score is that it is applied to younger and younger individuals who have just crossed 30 years of age, and it gives you a risk of not only 10 years heart attack risk, it also gives you a 30-year risk of cardiovascular disease. So it is kind of more comprehensive, and it gives you a bird's eye view of what's going to happen to you in the next 30 years or so. Again, if you look at what is the inclusion criteria for this particular score, it is again the age, cholesterol levels, the good cholesterol levels, upper blood pressure, which are similar as compared to the other ones. But here a different thing that comes up is the BMI. BMI is a body mass index, which is a measurement of how obese or how overweight a person is. And the second thing which takes into account is the EGFR, which is a measure of the kidney function. So if you're predicting a risk of a particular individual, you need to know his current kidney function as a status, and you also need to know how much overweight he is beyond what his normal weight should be. Similarly, it takes into account diabetes, and which is not included in the previous couple of scoring systems. Again, so that gives us an idea about, because diabetes leads to kidney failure and heart failure also. and it takes into account some of the other risk factors which are similar to the previous ones. The newer ones again, however, here are it takes into account your urinary albumin creatinine ratio. That means it takes into account how much urine, how much albumin are you secreting in your urine, how much is your hemoglobin A1C, which is a measurement of diabetes control. And also it gives you an idea about the social deprivation index, which is not very much considered as a part of coronary artery disease risk factor. But nevertheless, the Westerners, they have found out that if you belong to the poorer sections of the society, you tend to develop these kind of acquired cardiovascular problems earlier in your life. And the interpretation is labeled as less than 5%. If you get a score of less than 5%, you are deemed as at low risk. Borderline to intermediate risk between 5 and 20%, and higher risk is if you are more than 20%. Again, this requires a lot of individualized sessions with the doctor, and it's not as a simple that you put your system, put your all the labs in the system and get a particular score, and then you can done with it. Having understood all the coronary artery disease risk factors and problems and the risk prediction models, let us see how a bad day can look for any one of us. Watch out for these symptoms, especially you may be having a heart disease. And there's a lot of overlap of heart disease with gastroesophageal reflux disease. Plus, there is a variety of organs in the abdomen, in the chest, which can confound symptoms as that of the coronary artery disease. So, watch out for these symptoms like chest pain, jaw pain, pain in the left arm or back. If you're feeling breathlessness after climbing a flight of stairs, for example, previously it was happening on 2 flights of stairs. Now it is happening on 1.5 flight. You should be cautious. Excessive sweating is a very typical sign of a heart problem. Palpitation is abnormal heartbeat. If you get tired very easily, or if you get retrosternal burning or gas-like symptoms which don't go away with usual measures, then you should be aware that this could be the heart problem symptoms. Now, location of the chest pain, sometimes it is located at the typical location, which is under the breastbone, but sometimes it goes on the right side of the heart also. Typical heart pain is retrosternal, which is inside or behind the breastbone, and it may radiate to the left arm and to the jaw or to the back. But sometimes, uncommonly, it can go to the right side also. So the left cartoon representation shows the typical chest pain representation, but on the right side, you should be aware that sometimes it can happen on the right side also, and to the jaw, back, and the epigastrium also. So if you're not feeling better by taking usual measures, then you should think about considering and seeing a doctor. A very important symptom is autonomic nervous system activation. Autonomic nervous system activation is whenever you have pain or whenever you are anxious, there's a lot of autonomic nervous system activation that happens. It manifests clinically in the form of cold sweats. You may feel nauseated. You may have an episode of vomiting or two. Your heart rhythm may become abnormal. You may have a sinking feeling, or you sometimes feel pallor, and you may lie down on the floor also. So these are also very important signs which point out that your symptoms may be associated with that of a heart. On the right side, if you see the kind of pain that you're having, it could be a vice-like pain, as if some rope is across your chest or some heavy weight is kept on the chest. These are some of the common symptoms and the ways the people describe a typical cardiac chest pain. Women and elderly needs a specific caution because sometimes the symptoms can be very atypical or abnormal in these subset of individuals. So in women, if you see, the heartburn is more kind of a representative of a heart problem. The backache again is a kind of a more angina equivalent in these elderly individuals. At the same time, if they have got early tiredness and breathing difficulty, they don't sometimes necessarily present with chest discomfort, but these atypical symptoms, especially if the woman is more than 60 years of age, they should be really considered as equivalent to heart problems unless proven otherwise. So again, if you see people who are more than 75 years of age, irrespective of the sex, heart pain should be considered if there is a complaint of shortness of breath. In fact, acute delirium. Delirium is like an altered sensorium also. If they are behaving incoherently, if they are talking irrelevant things, that could be a sign of stroke. That could also be a sign of heart failure and heart problems. And if they lose consciousness, sometimes that also is a sign that probably their heart is running very slow, or they've had a period of long heart activity not happening at all. And similarly, the elderly male also, they tend to have more symptoms which are atypical in nature, and where the breathing difficulty and tiredness and altered sensorium could be the reason why these people might be presenting with heart problems. So any atypical symptoms which you cannot recognize, which you cannot explain by the usual assessment at home, should be considered equivalent to that of a heart problem, and early intervention with a doctor should be sought. Let's say if you have any of these symptoms, what is the one, how are you going to diagnose it? There are three basic tests which every cardiologist or every MD physician or even GPs, they can help you with are ECG, echocardiogram, and an exercise stress test. ECG is just an electrical activity. It is most important when you are having symptoms. A resting person with no symptoms, ECG is usually non-diagnostic. This is how it looks like. It is for the doctor to interpret about the changes which are happening on the electrocardiogram. This is a 2D echocardiogram, which is nothing but an ultrasound of your heart. The doctor does the ultrasound of the heart just to ensure that all parts of the heart are getting enough blood supply. Sometimes a part of the heart does not move, which is not getting enough blood supply. So it is an indirect way of diagnosing ischemia to the heart. This is an exercise stress test when everything is the above two exams are normal, and sometimes we use a blood test called troponins. If they are normal, then we may subject the person to this stress test to find out if they've got any blocks in the heart. So so the question is, when do we require an angiography? If any of these tests they become abnormal, the doctor may think about an angiography. It is one of the best tests to find out blocks in those small arteries of the heart, and it is in the setting of acute heart attack. Angiography is required with the intention of doing an angioplasty. Benefits of an angiography are it is kind of a more representative test. Sometimes the other tests they are not able to diagnose the blocks in the heart. Remember, there are a variety of other problems also with the heart. We are talking only about the blocks in the heart and myocardial ischemia. Just to give you a perspective about the angioplasty and the bypass surgery, the passing in line. So if you see it on the right side, as we discussed earlier, we see it in black and white. This before angioplasty, you see a block which is represented by a constraint over here in the black thing. Whereas after stenting, the black thing is the width of this black thing is restored, meaning that the unsuccessful angioplasty has been performed. In the bypass surgeon, the surgeon takes a vein from your leg or from your inside of the chest, and he attaches one to the aorta and the second beyond the blockages over here, for example. So in that way, both the purposes are that your blood flow to the heart becomes normal one way or the other. So it depends upon which person requires what. It's a matter of discussion with your treating doctor. Now, this is just a cartoon representation of a movie where we would just understand how the symptoms of heart attack they manifest from this particular individual person. So if this is a typical person who goes to the office, has got a stressful environment, and as we go inside his coronary arteries, we see this blood flow which is flowing. At the same time, there are projections inside his coronary arteries, which are nothing but the cholesterol depositions that we saw in the cross section. So if these cholesterol depositions they become too much, then the blood is not able to flow and leading to symptoms. And these symptoms for this particular individual can be chest pain, which is the most common one, but also pain in the arm, jaw, or back. He may start feeling tiredness or shortness of breath, nausea or heartburn, and he might sweat excessively. He may also have palpitation or uneven heartbeats. When any of this is experienced, he goes and sees the doctor. The doctor, as usual, does the regular work of doing an electrocardiogram, an echocardiogram, and a stress test. So this is the stress test which is being performed on this particular gentleman. And after this stress test, when they found that it was positive, they subjected the person to an angiographic procedure. So this is an angiographic images of this particular individual. And you can see there's a block in the proximal site somewhere here. It's a very important and a significant block. And they decide that this person would be amenable for an angioplasty procedure. So angioplasty is typically done in an operation theater, which is known as the cath lab. And in the cath lab, there are a couple of doctors and nurses, and there are small tubes that we insert through the leg or through the hand for performing of this procedure. This is how the doctor dresses up, the tube going inside the human body. And through this tube, we inject and see it on the cameras in the front of us. And this is a small tight blockage that they could identify. And we do it with the small wires and, there are small gadgets which are available to us. And this is a practical pictorial representation of how an angioplasty is done. So you pass a wire mounted on a balloon which is mounted on a wire and inflate it and clear the blockage. And then you put a stand so that the blockage does not come back. So this is how the procedure is accomplished. The person can go home either the same day or the next day, depending upon his clinical condition. Now let's come to the more important kind of a discussion about the prevention. So there are three levels of prevention: primordial prevention, primary prevention, and secondary prevention. So primordial prevention basically it means that you induct lifestyle, healthy food and lifestyle habits in children, so that when they grow up as adults, they don't develop the disease or delay the development of disease. So you can encourage them to go outside and play, spend less time on the TV and the video games, spend less time on social media, increase intake of salads and green leafy vegetables and salads, and discourage the use of kachori, burgers, etc. There are some nutritional and diet recommendations for in general for primary prevention. This is basically you need to take Mediterranean diet. So it simply implies that you take a diet which is rich in vegetables, fruits, legumes, and nuts and whole grains, and don't take saturated fat. Replace saturated fat with monounsaturated or polyunsaturated fatty acids. A diet containing reduced amounts of cholesterol and sodium is also beneficial. So if you look at what do we mean by unsaturated fat? So unsaturated fat is available in avocado, for example, seeds. All kinds of seeds have got a good amount of unsaturated fats, and you should abstain from saturated fats and trans-saturated fats, which are available in pizzas and frozen vegetable oils, fast foods, stored sandwiches, various types of cheese and red meats. So we should abstain these kind of things and go on more of a unsaturated fat side. We can have walnuts and almonds and all kinds of nuts. Avocado is good. All kinds of seeds are also very good. So when you have the correct balance in eating, our idea is to prevent the progression from left to right. And under no circumstances should you progress from left to right. If that means, doing toxic pills and surgeries, people would want interventions for somebody else to do it for them. But nowadays, the lifestyle change is also coming into picture in a big way. The window on the right side is not as empty as you see in this particular picture. More and more people are wanting to change their lifestyle and get into shape. How do you get into shape? Well, there are recommendations available for exercise and physical activity. Adults should be physically active, and the recommendations are two types. One is a 75 minutes of weekly accumulated moderate intensity exercise, vigorous exercise, and at least 150 minutes of moderate intensity exercise. So what do we mean by moderate? Well, moderate would be brisk walking, biking, active yoga, recreational swimming would be moderate. So this kind of activity you need to do at least 150 minutes of accumulated time in a week. You can spread that between 5 to 5 days, couple of days, some people can rest also. Or alternatively, 75 minutes of vigorous exercise, which would mean accumulated 75 minutes of either jogging, running, biking, which is more than 10 miles an hour, singles, tennis, and swimming laps. So it depends on how you want to do it. Either ways is fine. Again, to summarize about the high risk of blood which the blood pressure poses to the global attributable mortality is the most single important risk factor. So all of us should get our blood pressure checked at some point in time or the other, because it is the single most important risk factor which causes 15% of the deaths across the world. It is important for us to understand that blood pressure is not a knee-jerk reaction. You go to the GP, he checks your pressure is high, take a medicine. That's not how we should do it. We should check your pressure at least on 3 separate occasions, separated by 48 hours. And there's a proper technique and method to checking your pressure. You need to use an automatic blood pressure monitor if you must. Take an average of 3 readings and average of either second or third reading among the 3 readings, and do it twice in a day. And these pressures must be repeatedly checked under quiet and calm circumstances. And again, the results can be discussed with your doctor. These are the categories of blood pressure in the adults. Anything more than 130 over 80 needs some diet and exercise. Anything which is more than 140 over 90 requires medical therapy. In addition to diet and exercise, we would understand the impact which the blood pressure causes, is that every 20 millimeters of upper blood pressure rise causes 2 times more risk of developing cardiovascular mortality. So if your pressure is 115 versus 155, for example, which is 40 millimeters above the basic level, well, you will develop at least 4 times higher risk of dying from a cardiac problem. If it is 175, the risk becomes 8, and it exponentially increases likewise. To come to the next major risk factor, which is the diabetes, well, it's a simple blood test. You can start getting your diabetes checked after the age of 30 years. And this normal hemoglobin A1C is supposed to be less than 5.7. Pre-diabetes is 5.7 to 6.4, and more than 6.5 is diabetes. And how do you go about addressing diabetes once you diagnose it? Well, it revolves around intense diet and lifestyle modification. Along with that, you might need some medical therapy. I think it is best suited for you to discuss with your cardiologist or with your diabetologist or your GP or your MD medicine doctor. They will help you to find out the correct medicine for you in addition to diet and exercise interventions. Cholesterol again is obtained by a single blood test. There are many genetic factors which determine the level of cholesterol. So don't get shocked if you are very lean and thin and not eating anything which is high in cholesterol, but still your cholesterol is high, because a lot of genes control the cholesterol. A simple algorithm is the bad cholesterol LDL C should be less than 100, And for people who are at an intermediate risk, for people who are at a low risk, 116 is okay. For high risk people, we recommend less than 70, in some instances, less than 54. And another important thing is having a good sleep. So the recommendation society guidelines suggest that at least 6 to 7 hours of peaceful sleep or a restful sleep is what is recommended for everybody without having the need for stress. You might recollect that many people die at 3 o'clock and 4 o'clock. That's because of a lot of internal stress going on in the circulatory system. So if you have extra stress on your body, in physically or mentally, that adds to the natural stress, and then you can land up in a troubling zone. So sleep duration and quality is very necessary. You should try to formulate and architecture your quality of your quality of your day in a way that it takes into account an early rise, an early sleep, and adequate amount of rest to your body, so that you are rested not only physically but also mentally. So what can we do not to have a bad day in the office? To summarize, I just have one slide. Well, we would screen for the CKM risk. Nowadays, because of this, the new algorithm that has come in, fat is considered to be a very bad thing. And essentially, our recommendation will revolve around some of the major risk factors, as we just discussed. Your dietary patterns, the Mediterranean kind of a diet should be preferred. Physical activity, approximately 75 minutes to 150 minutes. Sleep duration, a peaceful, restful sleep for 7 hours a day, and avoid nicotine exposure. Control your weight, extra weight. Body mass index should be less than 25. And blood pressure, lipids, and blood sugar should be checked periodically, starting from the age of 30 years. And additional testing your doctor might consider. So he might do all these 8 things, and based upon these 8 things, he might give you a risk score. And if your risk score is intermediate, then he might do some additional things to kind of further refine your risk score. And also, among adults with 30 to 79, we can use the newer risk factor prevent risk score to give you a 10-year and a 30-year risk of heart attack, heart failure, etc. for the next 10 to 30 years. And that is going to be an eye opener for many of us who take our health for granted. Similarly, there is a CKM stage which revolves around obesity. So if you're obese and if your body mass index is little on the higher side, you need to again classify and see your doctor who can put you in under these categories. And remember, any person who is obese has a risk of heart failure, has a risk of kidney problems in the future. And it depends on why is that? Because the obesity not only is overweight, but there's a lot of other things which happen. It disturbs you metabolically, it produces insulin resistance, and it produces early diabetes. So all these things taken together at 30 years from now, for example, if you are obese, well, then these things will eventually lead to heart failure and kidney affection. How do we reduce the risk? Well, we reduce the risk by, first of all, assessing our risk, discussing our risk factors with the physician in detail, trying to prioritize our CKM regression. If you are overweight, for example, we need to do diet and exercise, and if necessary, some medications can be given. If our cholesterol is very high, preventive statin therapy is available. Now, there is a new class of medicines for diabetics who are overweight or obese. These are known as SGLT2 inhibitors and GLP-1 receptor analogs. This is best discussed with your cardiologist or diabetologist, so that this can be prescribed you well in time and you can get well in shape. And these things have to be have to be monitored and progressively monitored and assessed at periodic intervals, so that you don't miss on any of these important landmarks as far as your good health is concerned. And last slide also emphasizes on age appropriate vaccinations. So seniors should also get influenza vaccine yearly, because a bad influenza or a bad flu or a pneumonia can be sometimes difficult to treat. And pneumococcal vaccine can be administered once in a year, once in 5 years, once they cross 65 years of age. And obviously, there are some other inclusion things which you can discuss with the doctor. But people who are more than 65 years of age should consider a couple of vaccines periodically. And in the end, we wish you all of a very happy and a healthy life ahead. Thank you so much.
Thank you very much, Doctor. Thank you very much for a very detailed presentation. I think we couldn't have asked for a better one. Doctor, there's a question that has come, a very basic question. I think when I was introducing you, he may have asked. This is Mr. Jambunathan. His question is, what is the role of interventionists?
We come in the very end. So if you're not able to take care of yourself, we come in the very end. And another important thing which the interventions can help you is, let's say, in the God forbid, you are in the wrong zone, and if you're having a signs and symptoms suggestive of an acute heart attack, we can do something known as a primary angioplasty. So primary angioplasty is a treatment modality offered for people who have got complete occlusion of the arteries. And usually 6 out of 10 people, they don't reach the hospital. They die outside the hospital. You must be seeing many people, including several young actors, have died outside the hospital before they were even able to reach the hospital setting. So under those conditions, the best thing can be to save a life is an angioplasty. Now, what you need to do on your part is to reach the hospital early in time. So a stitch time saves nine. If you are able to reach early in the hospital where there is a cath lab, that saves a lot of time. And heart and brain are two organs in the body which are where the recovery is time dependent. So if heart is gone, it is gone forever. If brain is gone, it is gone forever. So if you intervene after a limited number of hours, for example, after several hours, the benefit is much lesser. So it is important. That's why about this presentation is to recognize the signs and symptoms, including the atypical ones that we discussed, especially in the elderly and women. They sometimes have breathing difficulties and fatigue and all. Don't disregard, don't disrespect those symptoms. Appreciate them and then seek medical attention as soon as you can. And the interventionist would come later if you require some kind of a stent procedure, if you require a bypass procedure, something like that. And obviously, interventionist would also carry, your treatment recommendations with you. So like what medicines you should be on, what should be your levels of cholesterol, for example, diabetes, for example, blood pressure, for example. All people, all fingers are not the same. So also every person is not the same. So every person has their different goals and targets depending upon how high risk is high. If your risk is high, your levels are target levels should be much lower. This is all the interventionist can help you with.
Right. Thank you. We have a question from Shamla Ravi. The question is, sleep deprivation is supposed to be a risk factor for heart disease. Is it okay to take sleeping aids like tablets to induce sleep long term to prevent heart attacks?
Well, I would say that there is no one-to-one correlation between taking a sleeping pill and preventing heart attacks. But definitely, if something is helping you, for example, a sleeping pill which can be taken for a short duration of time, it helps you to induce sleep and it helps you to rejuvenate. Well, there is no harm in taking it. I don't recommend taking sleeping pills for a long, long time to come. The best thing is if you can exercise a little bit before you sleep. For example, if you have your meal and you can walk 5,000 steps or 2,000 steps or 1,000 steps, that helps you, or up and down a flight of stairs, for example. Tire yourself down somehow. That induces sleep better than probably taking a pill. So your body needs some exercise, and pills should be there only to assist you in case your dietary and your interventions by diet and exercise modification cannot help you sleep better.
Right. Doctor, I have a question. One last question is, Doctor, I am 65. I have no issues of blood pressure, diabetes, and I get my medical checkups done every year. However, I have a hereditary of heart problems. Is there something that I need to be careful about? As I mentioned, I'm 65 and I'm absolutely hale and hearty, and I have a good exercise regime.
Hereditary of what? Sorry?
He has a hereditary of heart issues.
Hereditary?
Of heart issues.
Heart
Problems.
issues. Okay. Okay, all right. See, if you have all the other things taken control of, and if you have got only a risk factor as hereditary, I don't think there's any real need to panic. But obviously, you need to see a doctor. It's a good thing that you're doing your annual checkups. You need to just have your all the risk factors under control to the same extent as any normal person would have. Well, since the hereditary history is of several types, we need to understand what exactly is wrong with the
Right.
genes in your family, whether it is a premature heart disease or if it is a premature blood pressure or a cholesterol or a diabetes which is happening in your family. Accordingly, we can advise you to, let's say, for example, if you're falling in the intermediate risk category based upon your risk factors, we would probably put your target goals a little stringent, a little lower than probably usual. So let's say if somebody doesn't have a hereditary history of heart disease at all whatsoever, and he's also 65 years of age, and his levels are like, for example, 5 out of 10. For somebody who has got a hereditary history of heart problem, his levels we will adjust it to between 3 and 4. So we will adjust the levels of LDL cholesterol, for example, a little lower, blood pressure levels a little lower, diabetes control a little lower. So this is what we would do probably, but nothing to panic if you have got all the other major risk factors controlled, because genes and all, they are not supposed to be like the determining factor, but they would be aiding your risk factor moving a little left to the left or the right.
Doctor, I have one last question for you, a personal question. What do you personally do to ensure that you have a good heart health? And then I'm sure you have a very hectic schedule. You have a lot of procedures that you need to do, and obviously work is very stressful, right? And you live in a city like Bombay. Exercises is difficult, for 4 months it rains, all of that. So what do you do to keep a healthy heart?
Yeah, so I'm kind of little blessed because while as you introduced me when you introduced me, you said I was in Abu Dhabi. So while I was in Abu Dhabi, I had a clinic offer to come in the same building as where I stay. So I stay in the same building as my clinic is there. So that cut short a lot of time. That cut shorts a lot of commute time. And a couple of hospitals that I go to are very close by in the perimeter of approximately 2.5 kilometers. So I'm kind of blessed. I don't have to kind of run day in and day out. But yes, definitely I have to target my quota of 150 minutes. So I'm not the very vigorous kind of a guy who works out for 75 minutes in a week. I'm kind of a moderate intensity exercise guy. I go for recreational swimming laps. There's a swimming pool in my apartment. I do at least 3 times in a week the pool. I am the table tennis champion in my age category for my uh, building. So I do involve myself in some kind of the sport or the other. And once in a week, I do 15 minutes of treadmill. I use the same treadmill which is there in my clinic. So just before the clinic is closed, I run on the treadmill, and I'm usually able to make up to 15 minutes.
Great. Thank you very much, Doctor. Best wishes on World Health Day to yourself and to our entire community of heart specialists across India, across the world. Thank you very much for taking time out. Thank you to Hinduja Hospitals to facilitate this. We will be back once again next week, that is next Saturday at 5 p.m. So please be there. And as I said earlier, the edited extract, the edited video of this session will be there. So, Dr. Rajdev's very detailed presentation and all the points that he raised can be viewed again, and you can, take care of your heart health as always. Thank you very much, Doctor.
Thank you, Pradhaman. Thank you, everybody, for listening. Thank you. Appreciate it. Thank you, Hinduja Hospital, also for giving me this opportunity.